Good afternoon and welcome everyone. My name is Michelle Dodi Cabrera. I am a program officer with the Sacramento office of the California Healthcare Foundation. We are an Oakland-based philanthropy whose mission it is to work as a catalyst to fulfill the promise of better healthcare for all Californians. To do this, we support ideas and innovations that improve quality, increase efficiency, and bring down the cost of care. In the interest of transparency, I just want to let everyone here know that we are videotaping the session as it's being webcast simultaneously, and then we're going to post the video to our website indefinitely. So just know that you are on film. I am very pleased to welcome my colleague from the Oakland office, Mary Beth Shannon. She's director of our Market and Policy Monitor team and today's host for the briefing. Thank you so much.
Thanks, Michelle. So I'm thrilled to be here with Paul Ginsburg. Dr. Ginsburg is kind of a world-famous health economist. He has started his career early on at Rand Corporation, has also worked in academia, and was the founding executive director of the Physician Payment Review Commission, which was sort of a precursor to the current MedPAC committee. So he has a long history in healthcare, knows these markets across the country very well, both for the work that he's done here in California. This is the second round of regional market reports that we've released, that we've done with Dr. Ginsburg's group at the Center for Studying Health System Change. The first set of reports were released in 2009. Now, 3 years later, here we are producing a new round of reports in the same markets. So the reports that you have in your packet right now are from two markets, the first reports that we've released, which are Sacramento, which I hope is of interest to all of you, as well as the San Bernardino Riverside market. We have 4 more that are currently in production and should be released in the coming weeks. A set of 2 reports, one on Fresno and one on the San Francisco Bay Area. And then we have 2 reports that will be released probably in early December, which are going to focus on LA and San Diego. And then in January, 2 reports that kind of look at cross-cutting themes across the state. So what we found in these markets, and those will be focused in 2 areas, one on payment reform and one on the readiness of various communities for kind of the expansion, healthcare coverage expansion. So I hope those are going to be topics of interest to you. So they'll go out via our normal email distribution list, and they can certainly be found on our website. But today I would like to welcome Dr. Ginsburg. The Center for Studying Health System Change has been looking at regional markets across the country, and we asked him to do a similar kind of analysis here in California. And I think what you'll probably find most interesting among these reports is how different these communities are. So as Tip O'Neill once said, that politics is local, we firmly believe healthcare is local. It doesn't really matter on average what the quality or cost is. It really matters for people and their individual choices that they make. And these market differences, I think, are really interesting and enlightening. So with that, I'll turn it over to Dr. Ginsburg. He's encouraging people to ask questions as we go along, so we make sure it's relevant. Because we are videotaping and also producing this as a webinar, we will either ask people to use a microphone if we have one, or Dr. Ginsburg's agreed. He'll just repeat the question so that we have a record of that. So feel free to just raise your hand, and we'll track as we go along. So, Dr. Ginsburg.
Good. Well, I'm really looking forward to talking to you, and do want to emphasize that since we got a fair amount of time, that this will go better if you ask me good questions or just challenge me. And you're probably going to be right, because, you know, when you do this type of site visit work, you know, your main source of information is people you interview. And, you know, many of you in the room are people that perhaps we interviewed. We keep it confidential, so. And so in a sense, we can certainly be corrected. So, and as Mary Beth said, you know, not only are the variation in communities, you know, not only did we find variation across these 6 California communities, but of course California is distinct from the rest of the country. And I think the way I'll characterize the 6 communities is that there's Fresno, which doesn't seem to belong to California. That Fresno's healthcare system seems much more like what you find throughout the rest of the country. It's not odd, it's just not California, whereas the other ones all have some aspects of California. So this is my agenda. I'm going to talk about the communities before I talk about the cross-cutting themes. And this is the organization. And, we have been focused since we began in early 1995 on the organization and delivery of healthcare and how it's changing. And we've always focused on communities for a lot of our work. I think we differ from other organizations also because we're very active in dissemination, and that goes back to making sure the researchers write up their work in ways that are accessible to audiences in the world of policy and the world of industry. And so, as Mary Beth said, this was to follow up on around 3 years ago. We went to the same communities, but the focus on this study was a narrower focus. This one was really focusing on hospitals and physicians and the safety net on healthcare delivery. We did not do insurance markets, although we talked to insurers about contracting with hospitals and physicians and other providers. So we wanted to make sure to get the contracting in, but the main focus is on the delivery system in this study. And Mary Beth went through all that stuff. Here are the markets, and I have one comment about Fresno. Each of these markets is defined by the boundaries of the metropolitan statistical area. Fresno is different because in Fresno we went beyond the metropolitan statistical area to include a number of rural counties that surround the Fresno MSA.
Back, but I think we want to make sure we can get it.
Okay, sure. Oh yeah, that sounds better now. So anyway, it was a way for us to get some rural content into the study. And so our Fresno market is larger. That's where we have a lot of the discussion about rural health clinics because we were, branching out a lot more when we did Fresno. So our methods are, we interview healthcare leaders, and there are the types of organizations. We often, use what we call triangulation, that we don't write something up just because one person told us something. We want to get someone else's perspective. So when we're talking about contracting between hospitals and physicians and insurers, we want to make sure to hear about it from all those three parties. And that's a core thing. We also have a lot of quantitative data, and because it's California and OSHPD, the quantitative data we have, which is sprinkled liberally in our reports, is very useful and very rich. And here are some of the quantitative data. This is census data, showing how the markets vary in their socioeconomic profile. You can see up at the top, Fresno, by far the poorest, has the majority of its population below 200% of poverty. And then, we can group Los Angeles and Riverside, San Bernardino as the areas that have greater poverty than the state as a whole. And the other three communities is the ones that have less poverty, San Francisco Bay being the wealthiest area, although this chart really just shows whether you stay out of 200% of poverty or not. I'm going to review briefly the round one results for these communities and then talk about what changed. So, and actually, one thing that affects all of these, the first round was as the severe recession that's been officially over for a while, but we're still feeling, as it was beginning. And what I was really struck as an economist in doing that is how quickly the recession was being felt in healthcare. And there's a literature about how the economy affects healthcare spending and utilization. It's usually done at an aggregate level. And that literature emphasizes the very long lags. That so if a recession occurs, you might have to wait a few years to see the really substantial effects in healthcare. But I think for a number of reasons, this recession that we went through seemed to impact the healthcare delivery much more quickly. And some of the reasons could be the credit crunch, the fact that hospitals lost their ability to continue construction projects, and the fact that people have a lot more patient cost sharing in their insurance, so that they have to pay more for care out of pocket. So anyway, the economic downturn was a really big deal in most of the communities, and certainly in Fresno. Fresno had been growing very rapidly as far as population, and the market is quite geographically segmented. Even if we had not included the rural counties outside of the MSA, we still would have found many distinct submarkets because the distances are fairly large. I think a key thing that makes Fresno different is that Kaiser Permanente has much lower penetration in Fresno than any of the other markets we went to, and as well as other HMOs. There just, isn't much of an HMO enrollment, which again is what is normal outside of California. And there were something very specific to Fresno, some real provider capacity constraints showing up as posing a real access problem for low-income people. As far as updating Fresno, we didn't see any major organizational changes. Most hospitals weathered the downturn fairly well, but they had not, unlike the rest of the states, where hospitals are trying very vigorously to align with physicians, little seemed to have been accomplished in Fresno. However, there was some substantial expansion in hospital and clinic capacity, although we perceived that the access problems for low-income people were persisting. And Fresno has trailed the other areas in a number of dimensions in preparing for coverage expansions, like the low-income health plan, which is the program, in a sense, to advance on the Medicaid expansion included in the Affordable Care Act. Very minimal participation in Fresno, and also little collaboration among providers as far as physician shortages. Okay, Los Angeles, pretty different market. Los Angeles stands out because its hospital market is so fragmented. There certainly are some large, prominent hospitals in Los Angeles, like Cedars-Sinai, UCLA, but there's nothing like a Sutter in Los Angeles. In a sense, there isn't a hospital system that includes many units. So there are a lot of hospitals in Los Angeles and not really joined into systems at this point. And in round one, we perceived a growing gap between what we call the have and the have-not hospitals. And basically, the have hospitals are the ones that people expect to have in their network when they're buying health insurance. And if they don't have those hospitals, they don't want the products. And by having that popularity, this means that hospitals can obtain a very high rate from the insurers. In contrast, a have-not hospital, may not be distinctive in any way. There may be a lot of hospitals nearby that are similar in quality, and thus insurers don't have to have them in the network. So they have less clout. Physician market, highly competitive. There is some very large physician organizations competing vigorously with each other. HMO products have a very large market share. Kaiser Permanente is very significant in that market, and a well-developed and strong safety net. And by safety net, I mean the public hospitals, community health centers, etc., providers that really are focused mostly on low-income people. Now, what we found is that the gaps between the have and the have-not hospitals persisted, but they did not increase. And the reason is that payers are pushing back a lot more and resisting rate increases, large rate increases by the hospitals that had not had problems getting them before. And I'll go into how some of the techniques that they're using. Hospitals are very actively pursuing physician integration, working out relationships, really to prepare for provider payment reform and integrated care, needing to work with physicians. And in accountable care organizations contracting, it's been physician organizations like healthcare partners that have been the leaders. And they have not been doing this jointly with hospitals. They have been contracting as an ACO directly with the payer and taking on a shared savings basis the risk for hospital use as well as physician services. And one thing I should mention is that in California, which has always had a lot of HMO enrollments and has put physicians at risk through what we call the delegated model, for the last 10 or 15 years, physicians were only at risk for professional services. And hospital utilization was not something that physicians were at risk for. So that's where the difference in California comes in with an ACO, that now hospital risk is included as well, whether it's a joint initiative by a hospital and a physician organization, or even if it's just a physician organization like Health Partners, they are taking some risk for use of hospital care. We find the county safety net seems to be, which was strong before, particularly energized by new leadership, someone who was recruited from San Francisco, and there seems to be some significant redesign in care delivery in the safety net in Los Angeles. Riverside, San Bernardino, what strikes you is the vastness of the geographic area. And this does inevitably lead to, it's really a lot of little healthcare markets rather than a big metropolitan healthcare market because of the distances involved. And, you know, that market had been growing very rapidly. It was already experiencing the housing crash when we went 3 years ago. And providers, one of their main issues was losing patients seeking specialty care to Los Angeles next door. The very strong political support for the local safety nets. Economic decline has continued in this area, with horrible foreclosure rates, a lot of uninsured people. Kaiser Permanente is growing rapidly there, other providers feeling threatened, but growing concerns about physician supply, especially in the outlying areas. And I think this is something that, to different degrees, we really were hearing all over the states about concern about physician supply, especially primary care physicians, particularly looking forward at the expansion of insurance coverage, that of course here has started already with the low-income health plan. And it's not clear how that's going to be resolved. For some reason, FQHC growth has been slower in Riverside, San Bernardino than in other markets studied. May very well be a reflection of the leaders of the organizations and their abilities to pull down federal grant funds for expansion.
Paul, could I ask a question?
Sure.
So I'm interested in that idea of a strong county system in both
Yes.
LA and then San Bernardino. And do you think that's actually inhibiting the growth of these independent community clinics? Because there's a strong county presence, they're not developing as much and therefore leaving some of these capacity problems?
Yeah, that's not a problem in Los Angeles. I think Los Angeles had a lot of growth of private FQHCs, but I think that's a really interesting point about San Bernardino and Riverside. That's possible. I hadn't thought about that.
It's just interesting that different counties have chosen to have a stronger or less strong presence in their healthcare system. Some contract out a lot, some own and manage a lot.
That's right. There's something like Sacramento, strictly, we'll pay some money to some people, whereas San Bernardino and Riverside actually creating a public delivery system. Yes, Kathy.
Really interested in the finding in LA about physician organization. Oh, thank you. Really interested in your finding from LA about physician organizations taking the lead in developing ACOs and taking the hospital risk. Tell us how that fits with what's happening in the rest of the country.
Well, it's always struck me that if you can modulate the risk enough, that physician organizations, where they exist and where they're real organizations, probably can do a much better job in an ACO than a hospital can. For one thing, they have this opportunity to benefit enormously by reducing hospital admissions. And hospitals, can be conflicted about that. They need to fill the beds. I remember once talking to a hospital in a rapidly growing area, this was not in California, who had entered into an ACO-like contract with the local Blue Cross plan, that said, this area is growing rapidly. We struggle to raise capital funds. Not having to build another tower so soon looks really good to us. So we're fine about, reducing admissions. But basically, I think I think physician organizations can be better organized around efficiency, and also have the ability to then steer their patients to lower cost, more efficient hospitals.
But are you seeing it elsewhere in the country?
Oh, elsewhere in the country. The one thing I have seen is that in the second rounds of Medicare shared savings ACOs, surprising number of those are physician organizations. But in Sacramento, also rapid population growth in high-income, well-educated areas. Of course, you all know this, 4 powerful not-for-profit hospital systems, each with aligned physician groups. So in a sense, Sacramento is the most organized of all of these markets as far as the hospitals are in systems, the physicians are in significant physician organizations, either group practices or IPAs, and the physician organizations are aligned with the hospital. So each hospital has their own physician organizations that they're aligned to. Kaiser is particularly strong here, and the HMO product is very popular in Sacramento, even if it's not a Kaiser HMO product. CalPERS, has a large impact on this market. The contrast when it comes to the safety net, it's very small. I mean, part of that's because the area is generally well off, doesn't have as many low-income people as a percentage of the population as other areas. But community health center capacity is very limited, and here's a case where there was no public facility that might be doing that. Dominance of Kaiser appears to be increasing, and to us, Sacramento is the petri dish for new contracting and payment arrangements. And there's a lot in the way of narrow network products, global payments, and again, because this market is so well organized, I think that makes it primely positioned to do this type of innovation. And to do the innovation from a position of comfort, as opposed to innovation because otherwise we're going to go under, so we have to innovate some way. Yes?
Well, just a quick question. Who do you see taking global payments here in the Sacramento?
Well, I was just thinking about some of the ACOs, like the one between Hill Physicians and Dignity and who's the other partner? I guess Blue Shield. That is global payments. In a sense, what it is that because, they're continuing to get paid the usual way, but that then, calculations are made on how they're doing and spending per person, and that is what is shared if there are savings. So that's what I think I would think of as global payments. And actually, as an aside, a number of the ACOs that I've learned about in California are not something I would have called an ACO. But ACO is a very fashionable word now. They look like, if you're familiar with the alternative quality contracts in Massachusetts with Blue Cross Blue Shield in Massachusetts, and the other major carriers are doing similar things. It's really pretty similar, but they started that before Congress defined what an ACO is, and they've never called it an ACO, but it's really fairly similar to what we see in Sacramento. Okay, so I mentioned how the pressure on the capacity in the safety nets on the outpatient side seems to be very limited. Of course, there is no safety net hospital. All of the hospitals do some care for the uninsured. And the FQHCs have a real concern about losing Medi-Cal patients to for-profit clinics that have been growing because of the managed care contracting done by the Medi-Cal managed care contracts. San Diego, another area of high-income, well-insured population. Here, also like Sacramento, 4 large hospital systems with close hospital affiliations, very tight inpatient capacity. Plans at that time had very weak leverage with providers, and they were already turning to narrow network products because of that. An event then was that Scripps, which is one of the major providers, was shifting away from capitation to fee-for-service payments so it could get paid more. Its major competitor, Sharp, retained the commitment to capitation. And as I'll get to the next slide, I think Scripps has not come out well from that. There are no county-owned hospitals or clinics, but a very extensive network of private nonprofit community health clinics. In San Diego, the new inpatient capacity has come online. It's not considered underbedded anymore. There's increasing competition for patients in some of the affluent geographic submarkets, particularly for certain lucrative specialty service lines. And specialty access for low-income people came up a lot in San Diego as a concern of something that might be getting worse, particularly as the facilities move to the affluent areas. And we're seeing an increasing use of narrow network HMO products. And here in San Diego is where we're seeing PPO-based ACO models as opposed to HMO-based ACO models. And Scripps is starting to move back towards risk sharing. Finally is the Bay Area. And again, stable, highly educated, should have said high income, diverse population. And the Kaiser and the Sutter systems are the dominant ones. And they're very competitive. If you ask Sutter people, who's their major competitor, they'll say Kaiser. They won't talk about another hospital system. And I think there's a consciousness among hospitals in both Sacramento and the Bay Area that if their rates go too high or they get too expensive, they're going to lose out to Kaiser, and there will be fewer people enrolled in the plans that are contracting with them. Unlike San Diego and Sacramento, the Bay Area still has mostly small physician practices. And although there's a lot of interest in expanding medical groups, hospital foundations, and the independent practice associations, and very strong county support for a very well-developed safety net. There was a very substantial organizational change in the provider sector since we went there. Basically, there are 2 very large IPAs. There was Hill Physicians, mostly in the East Bay, and Brown and Toland, mostly in the West Bay and in San Francisco. And this all got jumbled up, where Brown and Toland and UCSF had a falling out. And now, actually, both IPAs are covering both East Bay and the West Bay, and it's becoming much more of a regional provider market. Doesn't mean that that many patients are going to travel across the Bay, but a lot of the provider relationships are now, much broader than they used to be. The independent practice associations have been vulnerable to the decline in the enrollment in the HMO products, but these payment reform pilots that they are involved in are like new life for them. Basically, usually they're not allowed to do much for PPO patients, but under payment reform, where they're sharing risk for those patients, then again they can do a lot. Some of the smaller safety net hospitals outside of San Francisco and Oakland particularly are struggling financially, and actually it's been a worry in both rounds about what happens if, say, Richmond Hospital closes, and what kind of shift and burdens will come to other nearby hospitals. And their safety net is very collaborative as well as strong, and appears to be very well prepared for reform. So here are some of the cross-cutting market themes. From round one, the aggressive Kaiser growth. We found that Kaiser Permanente was continuing to gain market share. One of the areas they were competing particularly effectively was in recruiting young physicians who found, the combination of the salary, the regular hours, and the IT to be very attractive. And we heard that from many people competing with Kaiser to recruit physicians about how attractive the Kaiser was for young physicians. They like the practice model. Kaiser invested substantially over the past few years, focusing on ambulatory care, had fully implemented its IT system on the second try, and had been pursuing a strategy really throughout California of insourcing, in a sense, bringing more of the specialty care into the organization. And I remember when talking to Kaiser people about it, one of the factors is it's the IT system. We want to get everything really into this IT system on a real-time basis. There may be other aspects for the make or buy, but I see that as pervasive. It involves building more hospitals, bringing in cardiac services that might have been outsourced to a community hospital before. So, and that trend seems to be continuing. The physician alignment. Let me see, we're still on round one. Oh, no, that's right. These are the continued hospital themes. I'm on to round two now. And I would say hospitals are much more focused on physician alignment, which, is not as easy in California as it is in other areas because of the corporate practice of medicine restrictions. So that, hospitals are not permitted to employ physicians in California. And hospitals have been able to create foundations within the hospital that can have a physician group, it can have an IPA, but apparently it's very expensive to do that. So it's something that the larger hospitals and systems have done, not that available to the smaller hospitals and systems. So the hospital medical foundations have been growing, and there's been more exclusivity in IPA relationships, both particularly primary care physicians, focusing increasingly on a single IPA, and some hospitals developing a relationship with a particular hospital or hospital system. And I'll just try to mention a couple of highlights. I think some of this stuff we've covered. One thing I want to mention is that the The seismic deadline in 2013 was a really big deal 3 years ago. A lot of respondents told me that they didn't see how it could be achieved, both because of the amount of capital needed to meet all the requirements and because of bottlenecks in the hospital construction industry, just not enough in contractor capacity with the specialized knowledge to build a hospital. And then, we're back and we see the deadline was relaxed, although a lot of construction is continuing that had been spurred by the deadline. So there's really been an expansion of hospital capacity in California. Some suspicion that there could be overcapacity in some markets, which will be a real change, but also it does provide opportunities to shift from inpatient to ambulatory. If you're replacing a facility, you don't have to build as many beds in the new facility. You can have more ambulatory facilities. So that was one of the stories. I think in provider leverage, we've seen some tapering off of provider leverage as far as more pushback by plans. And I think providers realizing that they're going to keep losing share to Kaiser if they don't. And I think that's been responsible for some of the interest on the part of providers in innovative contracting. I mentioned before the delegated model, which seems to be something that is unique to California. It grew up during the 1980s, maybe 1990s, and it was retained during the managed care backlash. As I mentioned, now, in the context of the delegated model, that ACOs and other contracts are, in a sense, broadening out the scope of services where the risk is being taken for which risk is being taken to go beyond just the professional capitation used in the delegated model. Let's talk about the new contracting arrangements. Certainly, I think we counted 8 Medicare ACOs in California. I think 6 were in the sites that we're covering. And a lot of interest by people we talked to in bundled payment contracting with Medicare. And unfortunately, the information hasn't come out yet from CMS as to who has bundled care contracts with it and what the arrangements are. We're finding that the public employers have been the key in initiating the commercial contracting innovations. And by public employers, I mean CalPERS, I mean the city of San Francisco, and lately the city of Los Angeles seem to have really been in the lead in crafting products with their carriers and provider organizations to do global payments. And the model tends to be this 3-way sharing of global risk on top of the existing payment methods. I think I mentioned that before. It is also often coupled with a narrow network. So in a sense, the part of being in an ACO arrangement in California often is that you're also going to be part of a narrow network product, so that the enrollees will be hopefully driven to your organization through the more attractive premium for the insurance product that is engaging in this narrow network with the ACO payment. A critical element which is standard for all ACOs global payments is data sharing. That providers are pretty blind as to what's happening with their patients outside of their own facilities. And this is why, I think Medicare has not been able to do it yet. I think some private carriers have. There's a need for the private carrier to provide real-time information to the providers engaged in an ACO on their patients. They need to know if their patients are showing up in someone else's emergency room, because otherwise there's no way they're going to know. We saw a lot of interesting new benefit designs. This is the narrow network products that, some products either exclude or provide a disincentive to use high-cost providers in their network. And in San Diego, Scripps is excluded from certain products by most major health plans. And there has been perceived a shift in market share toward Sharp because of Scripps exclusion from many narrow network insurance products. We also saw a product that limits network to one full-service provider in exchange, presumably, for lower rates, and that's the one here in Sacramento between HealthNet and Sutter. And also seen the reference pricing initiative with Anthem and CalPERS for hip and knee replacement. Essentially, Anthem and CalPERS have decided which hospitals that do knee replacement meet a quality standard, and they have set a reference price, and they will not pay higher than that. So they have provided their enrollees with a list of now 52 hospitals that have met quality standards, and they can go to without paying extra for a knee replacement. As far as the safety nets, some of the continuing themes were continuing to growth and demand for services, more uninsured people, more Medi-Cal enrollees, and safety net capacity has not been able to keep pace with utilization trends. Real challenges in the availability of specialty dental and mental health services. And what came up before is the role of county government varies a lot in providing services and programs for low-income people, and that's really striking. And, I don't think it even lines up that much with political orientation. There must be other things besides it. So, the small county roles of Sacramento, Fresno, and San Diego, I don't know how you put those together and that you would have expected that. Perhaps this goes back a long way. It probably does. There's been an infusion of a lot of federal money to expand access, I think the federally qualified health centers have had the good fortune that both the Bush administration and the Obama administration had put expansion of those organizations as fairly high on their health policy agenda. We also heard about the California Hospital Fee Program, which is one of these problems that you fiddle with the Medicare match and you get the federal government to pay more than they mean to. And this money has gone to the hospitals rather than to balance the state budget.
So there's a little bit of that, too.
Yes.
A
little bit of spill-off. Okay. It's actually, as being a budget-oriented federal health policy person, I've just been amazed at how, for the past 20 years at least, there have been these practices with Medicaid matching, and they haven't been shut down. And it's because there's been so much political support to maintain them. And I guess that's what happens when you don't have to balance your budget every year. I guess you can do that. Who knows with a debt reduction deal whether that might be clamped down in part. And I mentioned the low-income health plan. There is this Medi-Cal Bridge Reform waiver, which has incentive payments to public hospitals to support infrastructure development and tying future payments to outcomes. Oh, yes.
Paul, welcome to Sacramento. It's Albert. I just wanted to mention that the main reason for the distinction in the county safety net themes from round one is that San Francisco, Riverside, San Bernardino, and Los Angeles County all have very strong local initiative Medi-Cal plans that bolster their county health departments. And the other three counties do not. They're either geographically managed care, or in Fresno County, they subcontract the public side to a private health plan.
Yes, I think that really is a factor, and thanks for bringing that up. Albert Loeyball?
Yeah.
Wow, I haven't seen you in 30 years. Good. Good. Well, thanks for coming. Okay, and the safety net, the community health centers in California have really emphasized the medical home model. I doubt that's different from other parts of the country, and as well as their initiatives to try to integrate behavioral and mental health services better with primary care. It's really striking how it's easy to forget how in the various payment reform agenda with ACOs and bundled payments and medical homes that either Medicaid programs or the safety net providers have often been pioneers in them, and that's I think they've perceived the potential for them faster than other providers. And safety net providers are collaborating with each other more, sometimes to try to craft ACO-like agreements, and this is often hospitals with clinics collaborating, and also trying to get some health information exchange going, and which I think really can make a difference in identifying people who show up in a lot of different emergency rooms. Their clinics aren't going to know about it without some data sharing from the hospitals. A few comments about the low-income health plan. Most counties have set eligibility at 133% of the federal poverty level, which is where the Affordable Care Act will kick in 2014. Some counties, such as Sacramento, has set much more stringent limits, and some counties, like San Bernardino and Riverside, have set enrollment caps based on available funding and capacity, and those caps are very, very low. So in a sense, this plan functions a lot more in some areas than others. So here's some thoughts that, California's healthcare system, is distinctive. I think at the top of my list, I would say the large presence of Kaiser Permanente and how it impacts the rest of the delivery system. And I was recently doing an interview in Oregon, which also has a large presence of Kaiser Permanente, and you see the same phenomenon. In the sense that Oregon, particularly Portland, outside of Kaiser, is a heavily HMO market and the like. What I think is more unique about California is the independent practice associations. I think the reason that you have independent practice associations is because of the delegated model. Otherwise, there wouldn't be anything for them to do. But with the delegated model, there was an opportunity to play an important role. HMO products declined a little bit with the managed care backlash, but they are still very important in California. I think California HMO products always had more mainstream providers in them than you find in some other areas. I mentioned county leadership of the safety net in some areas. And then, of course, you have some state regulatory issues. The seismic standards for hospitals is, of course, unique to California. Mentioned the corporate practice of medicine, prohibitions, nurse staff ratios. The way that HMOs are regulated by the Department of Managed Health Care is also somewhat unique to California. And I remember talking a lot about the some of the requirements for health plans to drop a provider from their network made it pretty much impossible. Variations by community are very important, and there are variations in physician practice settings, large groups, small practices, different degrees of alignments with hospitals, the uniform concern about shortages, a lot of support for the HMO. The support for the HMO model varies, and again, Fresno stands out probably because of not having a large Kaiser presence as not having much support for the HMO model. And very active payments innovation that's building on the distinct features of the healthcare systems in the different communities. Again, I think a key motivation has been competing with Kaiser. And some of the barriers of integration between physicians and hospitals probably more significant in California than in other places. Thank you.
So I don't know what's happened with the microphone, but, oh, great. Are there any particular questions? Let me start off with one. You know, I'm kind of struck by your comments about the dominance of Kaiser and how that's shaped the California market. And of course, that's this idea of a relatively rich benefit plan and a tightly coordinated group of providers. How do you think that fits with this now growth really in much more high deductible health plans, more financial responsibility on the part of consumers, which seems to kind of be a trend that's in conflict with the Kaiser or centralized organization model? How do you think that's going to shake out?
Yes. Well, actually, you know, we didn't talk to health insurers about benefits this round, but you know, my recollection from last round is that Kaiser had introduced a lot of cost sharing into its products because Kaiser, you know, feared coming out on the wrong end of a selection pattern. You know, in a sense that if you could only buy rich comprehensive benefits from Kaiser, the healthy people wouldn't do it. So I don't know where they are today, but I suspect that they have followed along, you know, and developed systems where they can process, you know, calculate cost sharing, and you know, I think want to be in a position that, you know, you may have a large deductible, you're still buying into the Kaiser delivery system.
Yeah, it used to be interesting because I think in many places, if an employer offered multiple products, Kaiser was the lowest price option, and now usually it's the high deductible PPO plan that's the lowest cost option. So it probably is inducing healthy people to make a different choice.
That's a good point. Yes.
Hi. What is the price differential that you found throughout the state between Kaiser and the other similar HMO products? Like how much percentage-wise?
Yeah, and I really can't tell you. It's probably hard to compare because they're going to be different in the details. You know, many people in California have casually said, oh, Kaiser is always shadow priced. By that they mean that, you know, what premium should I set to get the, you know, compared to what the competitors were doing to get the enrollment that I'm seeking. So, you know, I suspect that they're close. I mean, I think probably what Kaiser would like is for people to either opt for the Kaiser system or opt not for the Kaiser system. In a sense, you know, I remember Kaiser has, I think, never permitted its plan to be offered as the sole offering by an employer, because the people who would just not put up with the Kaiser system, it would just as soon not have them. So, and I think that's what you know, most other choices today between, say, an HMO or PPO products, it's the same delivery system. It's just, you know, what happens when you go out of network? Do you have to have a primary care physician? But with Kaiser, you're really buying into the entire system in Kaiser. And so I think that's what actually dictates a lot of people's choices of Kaiser or not, is just how they feel about that delivery system. And one thing I should say is that this actually happened in the first round a lot. Many comments from physicians and hospital executives outside of Kaiser about how much higher Kaiser's quality is now than it used to be, and how much more serious a competitor they are because of that. And I think I think Kaiser has really transformed itself in many ways and has thus become a much more worrisome competitor to the rest of the delivery system.
And I'm fascinated by the work that you're doing nationally, and would just like to hear some of your contextual information about how our managed care differs from the nation and what your analysis here has been compared to our national situation for managed care.
Oh, sure. For managed care, I would say in a nutshell, California has never abandoned real managed care. In a sense, what I mean by real managed care, having, I think the delegated model with the capitated payments of physician organizations, whether it's groups or IPAs for professional services, really meant that California never lost the essence of managed care. That actually, I don't think many other states they ever had it, but then they gave it up very readily in the late 1990s in response to the backlash. So you're not the only area. Minnesota has it. It's less managed, but the Boston area has very high HMO enrollment. That's actually the result of a historical quirk, and it is reflected in the nature of the HMOs. Massachusetts used to have hospital rate setting, and a particular wrinkle of their hospital rate setting system was that the plan could not negotiate. The rates were not ceilings, they were rates. This is what you paid. But if you were an HMO, you were allowed to negotiate a lower rate, if you could. So a lot of plans became HMOs to get lower cost hospital care. And they continue to this day. They didn't do much management. I think their main reason for being an HMO was to get around that regulation. But but then the ACOs in the rest of the country have been mostly oriented towards either Medicare beneficiaries, and Medicare is like a PPO, or commercial PPOs, whereas in California it's much more based on the HMO platform because a lot of people are in HMOs, and since the HMOs don't have that much risk, it's really just professional risk taken by the physicians. There's scope for sharing additional risk. Yes. Hi, Patrick.
Thank you. Welcome to Sacramento, and thank you for a very interesting overview of some of the recent trends in California. As I recall in your round one work, looking particularly at the Sacramento and San Francisco Bay Area markets, you folks highlighted the importance of the hospital clout, the leverage of these multi-hospital systems in really demanding higher prices for hospital services than what was prevalent in Southern California. So I gather from your interviews that you're seeing some moderation of that trend, some pushback, as you've described. Can you elaborate on that a little bit more? What is the mechanism? Obviously, the dominant share of those multi-hospital systems in the market hasn't changed. So what other factors are allowing health plans to push back against the provider cloud?
Yeah. Well, I think in Northern California, it may be as much an issue of self-restraint by the providers rather than the plans pushing them back, because you're right, the structure hasn't changed. And the concern is that they, year by year, they're losing share to Kaiser. And so, some people think that's the reason that there's so much innovation in contracting with the ACO products, the narrow network. It's really a way of dealing with the situation of becoming priced out of the market. So this is the ultimate thing. You'd think, as far as provider plan leverage, that okay, you just push the plan and the plan raises its premiums and that's it, and the plan loses a little insurance volume. But here, if that happens, it has more consequences for the hospitals because Kaiser is such a large part of the system in this area, in the Bay Area.
I was wondering if you could comment on, there's been some dramatic changes in hospital net revenue over the past year. And one of them has reportedly reported an 86% reduction in net revenue. This is a major hospital system, Dignity Health. And Sutter's net revenues are also expected to decline fairly sharply. And I'm wondering how you can link that to some of these regional trends.
I wish I had a better sense of what was behind their revenues, whether it's just that they weren't getting the rate increases they wanted or whether there were other factors behind it. The dignity decline, was that just for California or was that nationally?
It's actually nationally, but they're 80 to 90% here in California.
Are they? Okay. Yeah, no, I wish I had a good answer to that. I mean, this could be, I remember when in another project talking to hospitals in Orange County, and they were all telling me that, under health reform, plans were going to become much tougher. And I think there's some substance, and, part of it is just you like to tell these stories of impending doom. But part of it is that the structure of the plans on the exchange, I think is going to lead to maybe just for those products, a much tougher plan negotiator, because the federal subsidies for people on the exchange, it's a fixed contribution. It means that your every penny of premium difference between plans, you pay that. So it's a relatively low-income population. They're having a fixed contribution. This means that premium differences across plans are going to be very important. So plans have to keep their premium down to do well in the exchange. And I think they're going to be very innovative as far as pursuing narrow network products. It may be that they just negotiate separately, the same way that today there's a different negotiation for Medicare Advantage than there is for commercial insurance, and Medicare Advantage rates are much lower. I wouldn't be surprised if there was also a distinct negotiation for exchange plans, and lower rates were paid for exchange plans than with typical employer-based coverage.
So I have a question. If we do this again in 3 years and look at these same markets again, what do you think we should watch for? What do you think the key issues on the coming 3-year period are going to be that might potentially drive costs or improve access?
Yeah. Well, one thing I'd really like to start thinking about is that, the biggest worry that respondents have is about primary care and, how that is resolved. And maybe to focus very specifically on how all the systems are fighting over primary care physicians and who gets them, and what are the implications for patients, say, in areas where they're really short. I think that in 3 years, you probably should, I hope to see a real maturing of many of the contracting innovations, but also a real capacity struggles with the expansion in demand for care by newly insured patients. So I think that's the, and then I guess I'd also watch what in the world is the federal government going to do next year to reduce its budget deficit, and that will have ramifications probably more dramatic than the payment reforms we're talking about now.
Should policymakers be doing something to try to address the disparities in the Fresno region, or do you think it just kind of self-corrects at some point?
Oh, I don't think it's going to correct. No, I think it's probably been there for a long time. I'm not sure what policymakers do. Certainly healthcare reform by reducing the disparity in the proportion of people with insurance, I think is going to do a lot of pumping more money into the Fresno delivery system and potentially expanding access because more people will have insurance to get access. I think the concern would be on the capacity side as to and perhaps if there was a role for policy, it would be concrete steps to try to facilitate capacity expansions.
Well, thank you, Paul. I think this has been really informative.